In this session, we're going to do some discussion about interpreting your results that the people who got their genotypes done. We'll talk a little bit about results, a little bit about some case studies, but I'm going to remind you from the talk that you've heard, talks you've heard earlier, this whole idea of precision medicine is personal, it's predictive, it can be preventative, and it's participatory. So we are at the participatory part of the session, and part of that participatory also has responsibility. And that is that we are not going to give you an interpretation of every one of your genotypes for you to go back with. What we are going to give you is information and the appropriate links to CPIC and those particular sites where you can look up your own information for all of the genotypes. You can very easily go to these sites, plug in your genotype, and identify what drugs may or may not have actionable variants and how you link to that. So we're going to go through some examples today. I want to start off by thanking the people and the organizations that helped generate these genotypes. I failed to put Genotech up there, I apologize. So Genotech provided us with the sample collection kits that people used. We thank them for that. Gina did all of the genotyping for us, and I particularly want to thank Sam because he did all the work. He put all the reports together, he put all the data together, he gave all the reports out. It was his organizational skills that made all of that part happen. He collected the samples, got them all to the right places. So I want to thank Sam for that in particular. Okay, so today I want to provide some definition of terminology. You've heard a lot of this terminology today, and I just want to make sure we're on the same page. Talk a little bit about the panel that was given to you and how to look at it and how to interpret it. Describe the genotyping method just briefly. It was a method that was used for your genotyping. I want to talk a little bit about the impact of some of the allelic variants as they might affect. A lot of the discussion you heard this morning was about your patient or people you know. No, this is about you. Today, you look at your panel, and we're going to talk about how you might interpret it. Provide you some examples, some of the most common variants that you can apply to look at your genotyping. Show some examples of how decision support tools are being generated that might become available as you start visiting clinics. And then maybe show you, Jeff is going to show you some additional surprising results of the analysis from this particular conference and the people who were genotyped. I think it's very compelling evidence for the process that we went through. So, this was the panel that was provided by Agena, and I can point out that somebody asked earlier, how do you decide on a panel? There are a number of companies that provide a pharmacogenomic panel. By and large, they have some of the same core genes, and then there are some other peripheral genes that may differ. This is a core panel that they provide, and part of that selection is due to the fact, as you can see on the slide here, there are drugs associated with each one of these genes that have been implicated in some aspect of variants that may impact the therapeutic efficacy or potential side effects. And I do note that not all of these drugs and not all of these interactions and variants are published as CPIC guidelines. However, your first page, the front page that you got on your genotype, are all genes and genotypes that do have clinical actionability based on CPIC guidelines. So as a participatory and responsibility, I'm holding you responsible if you want information of each of your genotypes. This is a resource to go to. The search engines here, as you saw from Kelly, the search engines to identify variants associated with your genotype are actually very straightforward on these websites that you can link to through CPIC. So if we go to an example, this is now a sample of what you should have seen. So this is an example of that cover page. These genes happen to be ones in the CPIC that do have guidelines for a number of different drugs. So on the left side, you see the gene. The variant you see in the RS number, for those of you familiar, that RS number identifies a specific nucleotide in an entire genome. So that particular position in the genome at that particular base is given an RS number. And you can see that there are a number of variants for each of these genes that are being tested. Each of them may have slightly different functional or phenotypic consequences. The genotype that is reported for you is in the genotype column, here shown for CYP2C19, star 1, star 1. And then the phenotype, or the interpretive analysis that Kelly was talking about, is also provided for you in this panel, indicating here star 1 is the extensive metabolizer, and on the far right side are some of the drugs that are impacted by that variant and that type of phenotype. And you'll also notice that CYP2D6 is there. CYP2D6 is probably the most complicated genotyping to do. It accounts for a large majority of the metabolism of drugs. There are probably well over 100 variants known. In addition, there are copy number variants, so you may have that gene allele repeated more than one time, so there are copy number variations, and you can imagine if you have more than one copy of the gene, that's going to increase its activity potentially. If you have, say, a normal function and you have a 3N, you're going to have 3 times the normal function as a sort of first rule of thumb. And then you'll notice that the others here are listed. On the second part of the material you got are the rest of the results. And you can look these up in CPIC and see if there are guidelines on these kinds of results and how they may impact the drugs that you might be interested in. The other thing to point out is this is a file that's not meant to be done today. That is, keep the file, and you may be interested in a new drug that you're going to get 5 years from now. There may be relevant information or updated information, particularly in CPIC sites. The other thing to point out is the disclaimer here, and I want to make sure I emphasize the disclaimer. The disclaimer is that this genotyping that's provided to you is not a clinical test. This is not a CLIA certified laboratory. I have all the faith in the world that the genotypes are correct. However, this is not a laboratory designated certified test. We're using this as sort of an educational, instructive potential. If you see a genotype that's of interest to you or concerning to you, you, I think, can provide this information to a physician who may be prescribing that drug, along with information for CPIC, because the chances are many of the primary care practicing physicians may not know what to do with this information. As a participant and responsible participant, you have responsibility then to inform the physician about information that might be available that would influence how a drug may be used in your particular case. So I do want to comment on the nomenclature because it was referred to several times today, and primarily most of the genes that are involved in these pharmacogenomic panels that constitute the core of most panels that you get out there are the cytochrome P450 genes expressed in the liver that are responsible for 2 possible functions. One is they may metabolize by activating a prodrug to its active form. There are a lot of drugs that you will be taking that are not active until the metabolic step occurs to create an active form. I'll give you examples of that. And then, of course, metabolism also is involved in clearance of the drug. So the activity of the metabolism can have a big impact on how rapidly the drug is clearanced, and the rapidity of how rapid the drug is cleared can have an impact on its efficacy, or if it's not cleared quickly enough, increased toxicity. And some examples here are these star alleles. And the star alleles were simply a way in which we were standardizing the nomenclature. And so they refer to a particular site and a particular base variant in the DNA. So every base variant of every gene that's listed in your panel may have a star allele. And on the second page, you'll notice that there is a listing of the star designation, the RS number, and the base alteration that's involved there. It makes it very easy to search those kinds of variants when you have that information. I was also asked by a GINA to make sure I told you that the little note at the bottom saying that this was all Sequenome, it's a GINA that does the testing. Sequenome is simply a client of a GINA. Sequenome was involved in developing technologies, but this is a technology that is housed at a GINA. Sequenome is one of their clients. So the examples of CYP2D6, you've seen some examples. The most important thing is that you have 2 alleles, one from mom, one from dad. So the important part of your metabolic activity is the combination of 2 alleles we refer to as the diplotype. Okay? In addition, there may be copy number variants. The processing that took place was your saliva kit was collected, the DNA was extracted, and I acknowledge also the University of Minnesota Genome Center and Kenny Beckman. They provided the extraction process to extract the DNA from everybody's kit. That DNA was then put into microtiter plates and shipped off to a GINA, and then a GINA went through a workflow in which the target genes were amplified, there was a primer extension, there was a reaction from the primer extension leading to a product that was evaluated by mass spec in terms of its size, and a report came out from a genome. More specifically, the way this works is actually quite simple, and that is that there's a primer extension after the amplification that ends just prior to the site of interest, the variant. So in this particular case, you can see right before that G, which is the tested variant, the primer is designed, and then as the base is added, you can see if it's a G or a C, it's going to actually change the molecular mass of the primer a little bit, because a G is not the same structure as a C, so the molecular mass that they contribute to the primer is slightly different. The mass spec system that's used in the mass array can actually distinguish the molecular mass of the G added versus the C. And when this is done in their system, it's actually done as a multiplex. And that is, you can add multiple primers, all having slightly different molecular masses when that base is added. And as a result, each one of these peaks represents the molecular mass of a primer that has been extended, and there are multiple variant sites here, so that the reaction can be multiplexed into one reaction. That makes it much more efficient, and then obviously there's a software program that can go right through here and read each of the bases as it relates to the primer, the location, and the RS designation, which then comes out as a star allele designation. That's the process your sample went through. So with the CYP2D variant, CYP2D6 variants as an example, you've heard about this. There are functional, reduced function, there are non-functional alleles, and there are duplications, all of which lead to an activity score. And it's important to note that as there was a discussion, that there's a lot of ethnic variation on the frequency at which some of these actionable variants occur. We know, for example, that about 5 to 10% of European Caucasians have the poor metabolic form of CYP2D6 with an activity score of 0. That is quite different in different ethnic groups. You can see the Asian populations tend to have a much lower frequency of that, and as was pointed out earlier, some Northern Africans have a very high level of ultrametabolism variants. In today's conference, we have 8 people in our audience that have that poor metabolism, which has clinical actionability to a number of different drugs. So there are 8 people in this audience that have that variant. Now, I do note here, just sort of out of curiosity, that the low form of that variant is more common in redheads. And it's a great question to ask medical students, why would that be? The answer is because red hair gene and the poor variant allele are closely linked in the genome, so they tend to segregate together in populations. One side story is when I showed this slide to medical students, I subsequently in my class evaluation got a complaint, and the medical students were complaining because Dr. Van Ness showed us a dead redhead on the slide. So in subsequent lectures, I have to put a disclaimer and say she's sleeping. She's not dead, okay? So there's an impact right now. In our audience, we have 8 people that have a homozygous 0 score variant of CYP2D6. What does that mean? Well, it means that in their scoring system, they've got poor metabolism, and the impact can be one of 2 directions, as we talked about. If you look at the list of drugs that are influenced, it's important to know, is the influence on a prodrug in which CYP2D6 is important to activate it, or is it on the clearance of the drug, in which case the CYP2D6 activity is important in clearing it and reducing the toxicity. So it's important to know the action of the gene enzymatic reaction on prodrug versus simply clearance. And standard in pharmacology, the whole idea of this sort of taking your drug every 3 to 4 hours is because as the drug enters your system, it reaches a certain target therapeutic dose, but obviously it metabolizes, which means you have to take the drug again 4 hours later to try to maintain an effective therapeutic dose. Obviously, if the metabolism is off and it's not working well, then it will reach higher levels that may become toxic. Or if the metabolism, and you have an ultrametabolism, which I don't think anybody in this audience is an ultrametabolizer, but if there were an ultrametabolizer, you may never reach an effective dose. So, case in point, here's Tylenol and codeine. So, case report is a 20-year-old woman gives birth to a healthy baby. She's prescribed sort of the typical Tylenol with codeine for post-delivery pain. A day later, she's becoming drowsy. They cut her dose in half, but 2 days later, baby's rushed to the emergency room, lethargic, slow respiration, and progressively becomes unresponsive and dies. Upon autopsy, the cause of death was determined to be morphine overdose. This is a kind of a scenario. What's the reason for that potential type of scenario? Well, it could be that the mother was a rapid metabolizer of CYP2D6, which means she was converting the inactive form to the more active morphine-like form, which gives you the pain relief. But because she was an ultra-metabolizer, she was becoming drowsy, but it was being passed on in the baby's milk, and the baby then succumbed to the morphine overdose. Now, one might ask the question, my dead redhead there, my friend there, and that is, if you weren't an ultra-metabolizer, what effect would the poor metabolizer, 8 of you in the audience, if you have the poor zero-activity form of CYP2D6, one might argue pretty convincingly and based on the guidelines of CPIC, codeine is going to be pretty darn ineffective as pain relief for people who can't activate it to its active form. So for 8 people in the audience, the CPIC recommendation might be codeine may not be your pain reliever of choice. Likewise, if you look in cancer patients and guidelines that are yet to come out from the CPIC, but there's been a lot of attention to the use of tamoxifen in breast cancer, and tamoxifen is also a prodrug. So again, if you look at your genotype and look at whether you have a prodrug CYP2D6 slow metabolizer, you can imagine that CYP2D6 is responsible for activating this prodrug to the active form. The endoxifen is the most active form of the therapeutic that's used in breast cancer. And one might argue that if you're a slow metabolizer, you may not generate effective doses of the active form of tamoxifen and therefore may receive an inactive dose. A precision medicine type of decision with a personal story. My sister had breast cancer, was given tamoxifen. Good news was she had very little side effects from the tamoxifen. The bad news is she probably didn't have the side effects because it's possible that she wasn't getting it to the active form, and the tamoxifen became ineffective for her breast cancer, and she passed away. Now, this was before any of this genetic testing was available. You can be sure today, I would be sure that my sister was tested before that drug was given. So now you start talking about, and you've heard some of this where all of this information now has to be fed into the databases. So what is now emerging out of these systems as clinics are starting to implement this into electronic medical records, and you heard about it, is all the stuff that goes behind the scenes so that the genotype that comes out of the genetic diagnostic service lab is now given a particular code. That code triggers a particular alert, and that alert can now come out as a report, and this is the type of report one of our other sponsors, Assurex, produces for psychiatric drugs. Now, this also happens to be precision medicine and a personal story. My stepson, who's autistic, was on a variety of psychiatric drugs with significant problems. We were losing control of Andy because he was spluttering, he was jerking, he was spasming, and he was having terrible sleep disorders. We've subsequently, through a psychiatrist, got his panel tested, and it turns out that Andy was a star 4, 0 score activity for his CYP2D6. And the recommendation over here in the red category, these are the drugs that Andy probably only should use with extreme caution because they may build up to toxic side effects. And it turns out that of the drugs in that list, we had tried at least 5 of them with Andy. And once we learned this information, we pulled him off of those drugs, went to alternative drugs that were not impacted by that particular genotype, and the spluttering stopped, the jerking stopped, and he's getting much better sleep. So personal story was we actually benefited from a pharmacogenomic panel. And then this is the kind of thing you might expect that the physician is going to get. So behind the scenes, all of the information is fed in. The important part is for the physician is to get a warning alert here saying you have a genotype that you may want to consider a different drug based on what the physician is typing in prescription. What that means also is if you look at all of these kind of drugs that are impacted by CYP2D6, these are not all part of CPIC recommendations, but one could imagine, and it has been published, consideration of altering the standard dose of each of these drugs based on the metabolic form of CYP2D6 in a patient. You either increase the dose if you need to increase it because of CYP2D6 or decrease the dose because of potential side effects. So the summary here is I want you to look at your report, and I want you to be able to look at the star alleles, and I want you to be able to go to the CPIC site and identify those list of drugs that may have an impact. But pay particular attention to those that have strong clinical actionability. And that list is not extensive, but it's important. Now, as I said, if you're concerned about it, this is not meant to be a clinical test which takes clinical action, probably should be confirmed in a clinical approved laboratory. But I think this is important information that you might be considering. The genotypes that are part of all of this are expected to have an impact on about 70% of all the drugs that you might be getting. Your diplotype then, as you saw, can be converted to a phenotype. Your CYP2D6 diplotype can influence a variety of drugs. 8 members of this audience have a pretty strong actionable variant as a zero activity, ultra slow metabolizers. And I think it's important to note that as we learn all of this, the decision support tools need to now migrate to the patients in the clinical practice to relay this information back to you. So that was one example of the CYP2D6. Now Jeff is going to come up and talk about some other case reports. I do point out one of our other sponsors here, OneOhm, a local company here, is also just about to launch their pharmacogenomics panel, and I'm sure they would be happy to talk to you, and you can go on site, web links to them as well. So Jeff is now going to talk about a few more case reports that might be relevant to your kind of diplotypes.
All right, thanks, Brian. So as Dr. Van Ness mentioned, our goals were to provide you with some information, also empower you to find out more information on some of your own genotypes on your own. And I wanted to extend the conversation by providing a little more information on a gene-based level. So Brian gave you a bit of information in depth on CYP2D6. And some relevant therapeutic implications. I'll talk a bit about CYP2C19 as another example, and we don't have time to go through all of those genes that are on the front page of your report, but sort of the spirit of this is to give an idea of what type of variation and functional consequences exist behind, sort of behind the scenes and how these might impact drug therapy. So I'll talk a little bit about this, and I thought it might be interesting to give a little bit of a case example to get a little bit of a feel about how this might be included in clinical decision making, and I'll use a psychiatric antidepressant case since that's sort of the therapeutic area that I'm involved with. So CYP2C19 is another very important drug metabolizing enzyme. I'd say second to 2D6, it's probably the most commonly referenced drug metabolizing enzyme in product labeling and perhaps also in CPIC guidelines. There are about 10 or 12 different common alleles that result in functional variation of the gene. There are a number of these, I think the panel covered most of these, that result in some non-functional enzyme activity. There are a couple of variants related to reduced activity, and then also a variant that increases activity. So what's interesting is that these changes in gene or enzymatic function can result from different underlying mechanisms. So here, for example, STAR2 is the most commonly observed non-functional variant, and that's due to a splicing defect in the gene. So essentially, the machinery that splices together the coding regions of CYP2C19 are altered so that a truncated version of the protein is created, essentially renders the 2C19 enzyme inactive and unable to metabolize any substrates. STAR3 is a premature stop codon. So that means that there's a base pair in the gene that essentially triggers the cellular machinery to stop reading across the gene and putting amino acids together. So again, you get a shortened version of the protein that goes into the formation of the enzyme. The enzyme essentially is absolutely non-functional and unable to metabolize any substrates. With the star 17 increased function fast metabolizer allele, these are variations that exist in the promoter region of the gene. So these essentially upregulate the expression of CYP2C19. So you have more enzyme in the body, predominantly in the liver, and when you have more enzyme around, it has an increased metabolic capacity to metabolize and subsequently clear substrates of this enzyme. And so you've seen a little bit about these phenotype assignments from earlier presentations, but this is an example of how this exists for CYP2C19. Again, we have a range of allelic combinations, or we call these diplotypes, that result in poor metabolizer, intermediate metabolizer, normal metabolizer, or ultra-rapid metabolizer. So ultra-rapid or fast metabolizer could be either 2 copies of the star 17, or as was mentioned earlier, there's sort of now this intermediate, there's ultra-rapid and rapid metabolizers. I have these grouped together here. And then those persons carrying 2 copies of the poor metabolizer alleles essentially have no function at all. And again, the frequencies of these types of variants are different across populations. And so these are gene-specific and population-specific. So while Dr. Van Ness mentioned differences in poor metabolizers and ultra-rapid metabolizers across populations, the same type of features exist for 2C19, but in different patterns. So for example, here in persons of Asian ancestry, the poor metabolizer phenotype is almost 1 in 5 individuals. And persons with 2 copies of the star 17 allele being ultra-rapid metabolizers are around 5%. So if we look at anonymized conference information, the poor metabolizer percentage was about 5 or 6%, which seems to fall about in the realm of what we might anticipate for based on what we know about other populations. And similarly, I think the 2 copies of the star 17 allele was about the same proportion as listed here. And if we grouped those with just 1 single copy of the increased function, that actually resulted in about 1/4 of the individuals in the population having some elevated function for CYP2C19. So drugs related to 2C19 guidelines, well, some of which were alluded to before. A lot of these are antidepressant types of medications. The exception here is clopidogrel, which is an antiplatelet medication that you'll hear more about from Dr. Weitzel's presentation this afternoon. And as Kelly mentioned, there's also an upcoming guideline related to voriconazole that's also relevant to CYP2C19. So again, these are mentioned, a lot of this is mentioned in some form or another in product labeling, and now there are guidelines to address how to use these in the context of antidepressant treatment. I'll talk about that in a second. One of the things I would like to continue to emphasize is that the impact of genotype, and CYP2C19 is no exception, depends both on the type of drug and the type of clinical context that one is involved with. So an example here that you've heard a few times and you'll hear a little bit more about it is the idea of differences in outcome based on whether you're dealing with a prodrug or something that is simply a substrate for a particular enzyme. So clopidogrel is an antiplatelet medication that essentially needs to be converted into its active form by CYP2C19. So the medication that you take is not the active form, but it needs to get converted by these enzymes. So in this case, the clinical outcome of a poor metabolizer is that you would likely have little or no therapeutic effect because of an impaired ability to convert parent drug to active metabolite. And so that clinical scenario is different than, say, a substrate of CYP2C19. So an example here is that citalopram, is an SSRI antidepressant that is primarily metabolized as a substrate through 2C19. So the medication that if you're taking Celexa or citalopram that's administered is the active component. And so a poor metabolizer of 2C19 then would have an impaired ability to metabolize active drug to inactive metabolites. So this has two potential consequences. The first of which is that you'll observe higher than expected serum concentrations, and so this could have some meaningfulness related to treatment response, but it also could influence the likelihood for dose-related adverse events. So I thought we have a few minutes to do this, and then I want to make sure that we leave some time for you to ask questions, because this is really about providing you the opportunity to learn more about your genotypes and empowering you to gain more information. But I thought as an extension of this exercise, it might be nice to put this sort of into a bigger picture. And I've included a case that's roughly based on some things that we've run into clinically, so that things are changed to make it appropriate for presentations. But I don't think it's all that dissimilar of a type of case presentation that might be commonly observed in the community. So this is an example of a 27-year-old Caucasian female patient who had a diagnosis of major depressive disorder and generalized anxiety disorder approximately 3 years prior at age 24. The presentation was notable for sadness, extreme guilt, suicidal ideation, sleep difficulties, and lasted approximately 3 months in duration prior to her seeking treatment. Didn't report any smoking. Alcohol use per patient was socially in social amounts, though maybe perhaps a little more at the time of her presentation. So she was started on citalopram or Celexa, which was a medication I just mentioned, 10 milligrams, which is a relatively low and conservative starting dose. Titrated to 20 milligrams per day, which is a very common initial target dose for this particular medication. And she experienced dose-limiting side effects and discontinued the drug just 2 weeks after reaching the 20 milligram dose due to restlessness. And so the clinical assessment here was that it was partially effective for clinical symptoms, but had dose-limiting side effects. So then, since there was some indication that the SSRI worked, but it was intolerable, there was a decision to switch to something else, which was paroxetine. And so paroxetine was titrated up to 40 milligrams, which is sort of on the upper end of the standard, very commonly used dose for this particular antidepressant. Continued on this medication for 3 years, still had about 1 depressive episode per year. With some ongoing complaints of side effects, and after some further inquiry, some questions about adherence due to side effects. So, in this particular case, a patient presents and the treatment team is interested in figuring out what to do next and if there's some way to optimize treatment for this patient. And so questions like this come up in the context of, well, might genotyping be helpful? And what do we do next? And so part of one of the things that I want to sort of resonate as a take-home message here is that genotyping might not be the end-all, be-all to our decision-making, but is maybe an important part of our toolkit to help inform treatment decisions. So first of all, with respect to might genotyping be helpful? When we've encountered these inquiries from the clinical realm, one of our return questions is, well, what are you thinking about doing next? Okay, so if a prescriber says they're thinking about drugs A, B, or C, one thing that's informative from a pharmacogenetic standpoint is if you get a test, is that going to be relevant to what you're deciding between some of these additional treatment options? If not, then it's not really useful to get the test. But if it is, it could be potentially informative. And again, drug treatment is not always not the only answer. There are augmentation strategies. There are non-drug treatment strategies interventions that are very helpful. But for the case, for the purpose of this case, I was going to focus a little bit on the genetics. So what I have down here are a list of 8 different antidepressants. I could have added a few more on here, but for the sake of space and ease of presentation, I listed 8. And in the context of desiring to switch to something else, I think the idea here is that there are a few different options, and these medications work in different ways. They have some different side effect profiles, and that in some ways, one can argue that they might all be in some sort of consideration depending on a particular patient without knowing genotype information. So in this particular instance, a genotyping panel was obtained. It was a psychiatry-focused panel that had a combination of drug metabolizing enzymes as well as some pharmacodynamic variants in the serotonin 2A receptor and serotonin transporter. Notably, the individual was homozygous for STAR2, so they were a poor metabolizer of CYP2C19, which may have been relevant to explaining the dose-related intolerance of citalopram, which is a 2C19 substrate. Okay, so now we have a little bit of genotype information. Really, the other ones are either normal function or some sort of intermediate activity where there's not really any firm guidelines to guide us. So the main take-home result here, as I look at it, is really this poor metabolizer genotype combination. So if we look at our list of medications, and we didn't really have time to go through all the mechanisms of antidepressants, but what we know now is that we could potentially streamline or prioritize some of our subsequent treatment decisions based on perhaps eliminating those that go through the CYP2C19 pathway, not necessarily because they couldn't be used, but perhaps to minimize some confounding issues of altered metabolism and dosing. And so then that leaves us with, instead of 8 medications, we have 5. And that, in the context of other clinical information, could be used to prioritize one of these remaining medications. So other considerations that might come into play for this type of patient are sleep symptoms. I mentioned that was something that presented early on. The types of side effects that the individual was taking from or obtaining from her previous treatments, and the degree of anxiousness. So some of these medications have properties that might be beneficial for sleep. Some might have properties that may be better or worse for an individual who also has an anxiousness component to their symptom presentation. And also the types of side effects that were observed from the SSRIs might be informative to determining whether or not another SSRI like fluoxetine might be a reasonable next choice or not. So I think some people would argue that there's not always a right next choice, but I think in this individual, a trial of venlafaxine, which is a CYP2D6 substrate, with serotonin and norepinephrine influences related to its pharmacology was tried, and that seemed to be a better treatment option for this particular individual. So, in order to leave time for a little bit of discussion, I thought I'd just sort of wrap it up there. But I always sort of like to put things in a little bit of the clinical context to show what sort of decision-making considerations might exist for this type of information. And to summarize, genotypes and phenotypes might differ across populations, and sometimes that's informative as to whether you might want to get a test or not. Again, the influence on clinical outcomes depends on clinical context and the type of drug. So the prodrug versus substrate, that's an easy example of that. And again, pharmacogenetics is not the answer to all of our drug treatment decision-making problems, but I think it can be an excellent tool to complement other pieces of clinical information when used thoughtfully and following, some of the evidence that's been presented earlier, as well as that will follow this afternoon. So one of the things that I asked for, just to wrap some things up here, without really knowing what might come of it, was that I thought, okay, so we've shown some information about how different metabolizer frequencies exist across populations, and you see poor metabolizers are 5% here, or 2% here, and the ultra-rapid metabolizers are a little less prevalent for CYP2D6. And so individually, you know, these things get to be a little bit rare, but what happens when you examine multiple genes at the same time? So I had two tiers of inquiry that I wanted to get sort of anonymous aggregate information on. The first is I took the 3 most common drug metabolizing enzymes that are referenced in CPIC guidelines and also in product labeling, and asked what is the proportion of individuals who had genotyping done that had some non-normal phenotype variation from these. So anything that was could be an intermediate metabolizer, poor, or ultra-rapid. So something that was just not genetically unaltered. And that was 85%. Because 85% of people have something that falls outside of the definition of genetically, that have some genetic alteration somewhere. And then I asked, well, I asked these at the same time, thinking these numbers might be a little bit lower. But then I took that panel that's listed on the first page. So these are the genes that are implemented into some sort of CPIC guideline, and said, okay, so what's the proportion of individuals with any non-normal metabolizer or non-normal like receptor function phenotype, so not just carrying a variant, but phenotype for any of these. And that was 100%. And at first I thought, no way, that can't be, that's too high. But then when we were reviewing this, and Dr. Jacobson showed slides about this, I think there were other slides shown about this, that's actually a common observation when you investigate these panels of genes. So one thing at a time, the variance is fairly rare, but the likelihood that somebody has something that may be relevant to commonly prescribed medications when you look at just 6 or 7 different genes is actually pretty high. So anyway, I thought that was fairly impactful and surprising in a useful way, and thought it'd be helpful to relay that information. But anyway, that's what we have for slides as part of a presentation related to this. But I think we have a few minutes left that we could entertain some questions from the audience related to what you got, how to think about it, what to do about it, or anything else. But thanks for your attention, and we're happy to answer any questions. Amit.
Hi. So I have a question. I mean, I don't know whom to ask. So there are 68 SNPs that you actually studied here, right? And then there was the CPIC guidelines where you can look up each SNP one at a time and see what are the actionable variants and which drugs you can use, which drugs you shouldn't be using. But say, when we do a genotyping, or say a whole genome, any exome study or RNA-seq study, you get like a VCF file with number of variants. Now you can go to CPIC site, each one after one another, and check which drugs are active, which drug you shouldn't be giving that person. But people from Assure X and Agena and Onome are also here. So basically, instead of doing that, can we upload a list and say, it gives me an information from the VCF file that this particular person should not be given these drugs because they have this mutations or SNPs. This person cannot be given these drugs. So instead of like looking up one after another in a PharmGKB site or a CPIC site, can we upload a list and get the information?
So the question is, can you upload a list and get metabolizer or some sort of recommendation information? And Kelly might be able to correct me, but I don't believe there's that capacity through the CPIC portal. There are other third-party programs that exist. Prometheus is one that I haven't used, but I've heard about using, where you can upload a list of a file of genetic variants identified by RS number, and then it will create some rough clinical links to research studies or things that might be informative.
Yeah, like for example, ANOVAR is one of those, but it doesn't give you a final drug information. It gives you like links to research done, like PubMed IDs. Like, for example, if you do it one by one, PharmGKB and CPIC also does that. But yeah, I was looking for something in the range of like having a list of drugs for and against.
Yeah, so I think the, what we provided phenotypes on are those variants where that translation is fairly clear. And there are other places where there are a number of associations, but what the clinical relevance are and how that gets translated into a phenotype in a way that would be necessary to have that sort of that workflow is something that's still a work in progress.
I think, Amit, maybe translational software out of Seattle, which it's focused just on the software systems of predicting outcomes from genotypes. I think translational software out of Seattle may actually have that information.
Is it available or accessible?
That I don't know. That I think they contract with diagnostic companies. Whether it's available to you, probably not.
So we've talked a lot about the applicability of these results, the genotyping results to liver tissue and metabolism in the liver. These genes are expressed in other tissues as well. Is there, should we be able to interpret these results in relation to these other tissues, or is there, an issue with that?
So the question of tissue specificity related to these genotypes is a good one. So for example, CYP3A4 and 3A5 and P-glycoprotein are enzymes and transporters that exist not only in the liver, but also on the gut barrier, and so they have some implication for absorption and end result distribution of medication. So I think what we know is that the functional consequences are perhaps not all that different across tissue types. The magnitude of perhaps clinical influence may depend on, the disposition of a drug that you're talking about and whether it's predominantly a liver-based metabolism or, there are some studies that have looked at variants and how they're expressed in the brain and whether that's meaningful for the disposition of perhaps psychotropic drugs. And that's an area that's relatively still somewhat undefined, although it seems to make sense that there'd be some meaningfulness there. Good question. Any other questions? Thanks for your time. Hopefully this was helpful and informative for you. Thank you.